All right, let's continue on with our topics in pathophys. So today we'll be talking about inflammation. So inflammation is a reaction that's happening in order really to cause healing, ideally. If it goes too long, we're going to have damage to the tissue, okay? Usually they say about 2 weeks is acute inflammation, 2 to 3 weeks tops. After that, that's chronic inflammation. We're causing tissue damage. So lots of things can trigger inflammation. So we have here like chemicals from outside sources like bacteria, or chemicals from within us, okay, like cytokines, histamine, interleukins, TNF. What can trigger those are we're looking at these patterns, pathogen-associated molecular patterns, okay? These are patterns on the surface of these organisms that our immune system will read kind of like Braille, and from there understand that is foreign, that is bad, let's respond. Okay? So, advantages, disadvantages. We're bringing things to the area. Blood, white blood cells, clotting factors, okay? All of that to deal with it. And this initiates the adaptive response system, the adaptive immunity. And we're going to talk about the two sides of immunity, innate and adaptive. Adaptive is the one you build up, the special library of information every time we get sick with something or exposed to something, okay? So, mediators of inflammation, here we talk about complement. Complement are these proteins that are floating around in our bloodstream that, when activated, can do several things for us. They can cause vasodilation. They can cause to kill bacteria. They can increase opsonization. So we'll look at different things. There are populations out there that have deficiencies in complement. It's pretty rare. But that is like a genetic disorder someone could be born with. And so they'll have like all these little different infections, like this bizarre situation where they're getting sick more than the average person. Okay? So whenever we activate complement, and there's like 3 pathways for it, the end result is kind of the same. So one big thing here is opsonization. C3b will stick to the surface of like the bacteria. And when it does that, we get an attraction of white blood cells to it to want to phagocytize it, okay? Eat it. I would make the analogy of this. The bacteria is an apple. White blood cell sees it. Yeah, an apple's good. You know, everyone likes an apple. But opsonization, adding C3b, is the same thing as taking that apple and coating it in caramel. And now it's a caramel apple. And everyone's like, yes, I want that. No judgment. Okay. All right. Chemotaxis, so it can cause the attraction, white blood cells. This is MAC, or membrane attack complex. So with this, when we attach these complements to it, it'll punch holes into the cell membrane of like the bacterial cell, and they can't stabilize. They can't maintain homeostasis. And so what happens is the cell will just lyse. Water will rush in because they have more solute inside of them, and they will lyse. Okay. And then anaphylaxis so this is where we see histamine. Okay. So the release of histamine causes vasodilation. You got to remember, it's not only about getting things through the vessel to the location, right? Like it's riding like the highway to that tissue, but then if we look at the wall of the vessel, as we vasodilate, we open up the gaps between the endothelial cells that are lining the blood vessel, and that allows things to migrate into the tissue. Clotting. So clotting, is part of the healing process. We have a inactivated structure, or a zymogen, okay, where it's floating in our bloodstream, and through the clotting cascade, we activate it into fibrin. Fibrin is what causes the clot buildup, this mesh network to close up a wound, okay? Here. This point down here. Increased vascular permeability, vasodilation, pain, and contraction of smooth muscle. So it's off topic, but it's interesting. Lisinopril. That is the medication, number one medication for majority of populations given for high blood pressure. Okay? So what it does is it dilates the afferent arteriole going to your kidneys. The flow into your kidney is bigger now. And by doing so, you increase filtration of your blood, your kidneys work more efficiently, and you get rid of fluid volume, hence lowering blood pressure. They'll even give like a super low dose. So like the intro dose for blood pressure control is 10 milligrams. And they'll give like a 5 milligram to diabetic patients to increase flow to the kidneys, perfusion of the kidneys, and protect the kidneys from the diabetes. So a pretty neat drug. Downside to the drug is it causes an accumulation of bradykinin. And when it does that, it causes this dry cough due to this last point here. The lungs are a little irritated and it causes a dry cough. So that's the random side effect on that drug, which is kind of neat. And so if that's the case, they'll switch them to like losartan or something like that, one of these ARBs. But if the patient tolerates it, they don't care. This little dry cough here and there, no need. But that is the reason. It's an accumulation of bradykinin. All right. So how do the white blood cells know who to attack? Well, they're reading these PAMPs, okay? The pathogen-associated molecular patterns, the braille on the surface. They're using PRRs, pattern recognition receptors, okay, or toll-like receptors. And they're reading this braille, and that's how they identify that it is foreign. So the problem is when you talk about like resistance, for example, what happens when an organism changes its PAMP? Your immune system can't identify it, okay? And they can do that pretty rapidly. So that's something to keep in mind. That's one way to evade immunity or immune system. So what would happen if inflammation was systemic? You're in big trouble, okay? If you dilated all your arterioles, arteries, everything, blood pressure tanks. Heart rate goes through the roof. If you increase capillary permeability, volume will leave the blood vessel and go into your tissue, and your blood pressure will drop, heart rate through the roof. And then clotting activation. This is really where you start to talk about like DIC, disseminated intravascular coagulation. You clot and then you bleed, and then you clot and you bleed, and you clot and you bleed. It's very, very dangerous. If you've watched any movies like Ebola and they're bleeding out like everywhere, you know, the IV line, all of that, that's DIC. Amniotic fluid getting into the mother's bloodstream can cause DIC. Giving someone the wrong blood type, an ABO incompatibility, can cause DIC. Trying to think what else. Toxic shock syndrome, leaving a tampon in for too long. The organisms that are on your skin, some of them possess the toxin that'll trigger your immune system on such a grand scale, you will enter DIC. This is also, you're talking anaphylaxis. And so that's why we give epinephrine. Epinephrine causes vasoconstriction. Epinephrine opens up the airways. Epinephrine increases blood pressure. Okay? So that's what we're trying to reverse in that situation. All right, macrophages, neutrophils. So we have several different types of white blood cells. They all have different jobs. They need to be able to communicate. So like interleukin-1, for example, it activates monocytes. Monocytes are like your Pac-Man, big cleanup crew guy. Okay, they have pyrogens. Interleukin-1 works as a pyrogen, meaning it will hit your hypothalamus and it will start the process of increasing your body temperature. And it's not really, we used to always say, oh, the increased body temperature of fever, kills bacteria, stuff like that. Not necessarily, to get that hot, you would start damaging your tissue, but fever is important. Fever upregulates our activity of our cells, our ability to clone our white blood cells, how much they react, okay? Fever is a good thing. I always got to tell students, fever is a good thing. Don't just immediately take Tylenol and all that. Low-grade fevers are safe. Low-grade fever is up to 103.9. Okay, so after that, the problem. After that, you're gonna melt your brain. Okay, you're gonna mess with protein structures. That's really what's gonna happen. So, interleukin 6. So this is what's called an acute phase reactant. So during this acute process, we can see elevations in this reactants. It can be an indicator of inflammation. And TNF it causes cell death, apoptosis, so that commanded cell destruction. The problem is it can be excessively released. So this is where this guy comes into play, catechocytin, and it causes cachexia. What happens is in cancer, there's an overstimulation and release of TNF. And so they start to break down their tissue excessively. And so they lose a lot of weight. That's part of the extreme weight loss in cancer. Here, this is just showing how these white blood cells, due to these chemical communicators, can adhere to the endothelium and then walk through it. And that's your diapedesis. And they're walking over to whatever the tissue damage or where they're needed in general. Okay? Phagocytosis, so just a little refresher on here. Create the little pseudopodia, and we pull in the structure into a phagosome. We'll fix a lysosome to it, creating the phagolysosome, destroy it, get rid of it, waste. Now that's if it's a regular situation. If it is a white blood cell and this was like a little bacteria cell and he had antigens on the surface, well, the next part could be we're going to present on what's called MHC, and we'll talk about that. And that's how we start to alert the rest of the immune system. So if someone has an issue with white blood cells, a certain lineage, stuff like that, increased risk of like bacterial infections, viral infections, all of that, because the very beginning of their adaptive immune system is hindered. Okay. Mast cells. So mast cells play a big role in like allergies. Okay. They degranulate. When they degranulate, they're releasing histamine, these different leukotrienes, prostaglandins, and they can cause like closing up of airways, and so asthma. Okay, so mast cell degranulation you associate with like allergies, hives, all of that. So what we try and do is we take like antihistamine, stuff to bind to the histamine and regulate it. Or we take stuff that tries to blockade the mast cell from degranulating. So like, what was it? Singulair is the drug name. That's the brand name. It was like Monteclast, I believe, is the generic name. And so patient would take that year-round, day after day. And what it does, it binds to the receptors here. So when the allergen comes in, the allergen can't bind. It is blockaded. It is a competitive inhibitor. The mast cell can't degranulate. You don't get the symptoms. Okay? Another way we deal with this is we make them degranulate. What if we control how much degranulates to where it's not enough to cause symptoms like anaphylaxis, but wear out these mast cells, empty them, so that if you come into contact with your allergen that sets you off, there's nothing to degranulate, or very minimal. And so your reaction is very small reaction versus full-blown anaphylaxis. That is desensitization. That's exactly what that is. So when someone's allergic to peanuts, we give them a little dose, minor dose of peanut, and then we give them a little more, to where we degranulated those mast cells. And then what happens? They skip 1 week of shots, and what do they got to do? Start all the way over in the beginning. They're coming out with some new stuff. There's a new one that just released recently, where it's like an injection and it covers them for like 6 months or something like that, which is pretty wild. I think it's only approved for peanut allergies currently. And there's another one they've created where it's a pill. Instead of doing shots, there's like a pill that they can do at home. So it's pretty neat. Pretty neat. All right. Eosinophils. These you think about like worms, okay? These are also related in allergies. A lot of we think like food allergies would be the thought process here. Because we live in such clean world now, we don't have worms to deal with. So what happens? The eosinophil gets bored and finds something else to attack. the the thing here is we used to tell parents, don't give your kids peanuts or anything until they're 6 years old or whatever, and then you can start exposing them because we don't want their system over. And we realized that was a big boo-boo. You have to expose very early. So now they tell like mothers, you eat peanuts or peanut butter or handle peanuts, whatever, and then feed your kid like from you or touch them, stuff like that very early on. And I think they say at 6 months they should be getting peanut butter to reduce those peanut allergies. The early exposure tells these cells that this is part of your environment. This is not something I should be attacking. And so we reduce a lot of the issues there. So acute phase, this is that acute inflammation. So we can see in here I have 8 to 10 days. It depends on the book you look at, 2 to 3 weeks. Okay. Chronic, I have 2 weeks or longer. Okay. C-reactive protein, this is another protein we can measure and look at and say like, okay, they have elevated levels. They're having this chronic inflammation potentially. And so it doesn't have much value because it doesn't tell you like anything beyond they have inflammation. But you could track it, for example, or erythrocyte sedimentation rate, ESR, and that's another one that indicates inflammation. And you could track it and trend it and see like, oh, they're getting better, it's going down, or they're getting worse, it's going up. That's really how it would be used. All right, exudates. So a couple different exudates here. So we have serous. This is early on typically, and it's very watery. It's clear. So if you ever had a wound and like you squeezed it, or a mosquito bite, you squeezed it and this clear fluid comes out, that's serous fluid. And really what that is, it's plasma minus all the proteins and all that good stuff. Okay, hence the clarity. Fibrinous. This is where we start to get proteins in here, and really the big proteins you're talking about are your clotting agents, these two. Purulent, this is the appropriate term to talk about a wound full of pus, all right? It is not the other word that is coming to your mind, and if you don't understand why, spell it out and you'll understand why. Purulent, okay? Purulent. All right, hemorrhagic, this is where there is blood in there. All right, so here, like pneumonia, for example, there is fluid in this lobe of the lung, and that's why it's opaque. That is not normal. You can see heart here, okay? Diaphragm. You can see trachea, okay? Hantavirus, this is one nasty little bugger. It causes pulmonary edema. So what you're looking at, we are inside the alveoli, the actual like breathing sacs of the lung, and they are lined by simple squamous cells, and there are capillaries wedged in there. This space is where the air is coming down into your lungs and then exchanged through that wall into the capillaries. There shouldn't be anything in there. That's what pneumonia is. By putting fluid in here, you can't breathe through the fluid, and so it blocks that diffusion of the gases. That is fluid. That's what we're seeing here. Okay? All pneumonia, that is the end result. It doesn't matter if it's viral or it's bacterial. It creates solute in there. It damages the cells. Fluid enters, or we damage the cells and we change them over into collagen and they don't diffuse. Okay? All right. So other signs of acute inflammation, fever, which is good, leukocytosis, that migration of white blood cells, in acute phase. This is ESR. So what happens is when there's increased inflammation, the sedimentation rate is quicker. And what happens is this phenomena, for some reason, the red blood cells form Rolex. Basically, they stack on each other. And so the faster it settles, inflammation. Okay? Chronic inflammation, this is where we start to damage the tissue. So you get infiltration of macrophages, white blood cells in general, and they cause damage to the tissue as they release chemicals. They could be oxidizing agents, for example, and it will damage it. So right here, this is a granuloma. Right? That's just excessive white blood cells in the tissue. That is not normal. So here, this is a nice little showing, like a chart showing you like how long it takes roughly for these guys to respond and what stage we're in. So you can see platelets are the first. They're everywhere. Okay. Neutrophils are the first white blood cell. How about that even? Right? And then after that, you can see we start to remodel. So that's why you need the fibroblasts. We're building the tissue. And macrophages come in pretty early to clean up the debris. Lymphocytes to learn. That's your adaptive immune system right here. Okay? So it takes a little bit. All right. And that is the end of inflammation.